Alaikum. Welcome, everyone. This is Dr. Seja, consultant nephrologist from Sultan Qaboos University Hospital. And on behalf of the educational team from the OSNT family, it gives me great pleasure to welcome all of you, distinguished speaker, and also our audience, Prof. Hisham Sayed and Dr. Isa Salimi, and all our audience. And I would like also to extend our warm welcome to our dear friend and colleague, Dr. Yasser Al-Mullah. He's our friend and he's worked before with us in SQH, and then he moved to UK. And Dr. Al-Mullah, he is highly respected consultant and transplant physician at Salford Royal Hospital, which is part of the Northian Care NHS Foundation Trust. Also, he is honorary consultant nephrologist at the Edinburgh Hospital, Cambridge University Hospital. His expertise mainly in transplant nephrology and dialysis, including home dialysis, and he's also have long been a leader in advancing the care of the patient with complex renal conditions, and also he showed some interest in academic research and PhD supervision. So he's with his collaboration, we have a privilege also to extend our welcome to our guest speaker, Dr. Saif Al-Chalabi. He is a registrar and nephrologist specialist. He will talk today about the chronic kidney disease and its relationship with the cardiovascular and metabolic syndrome. So I'm really happy to have both of you, Dr. Saif and Dr. Yasser, and thank you for your accepting our invitation and your kind time and contribution to our regular OSNT seminar online. We are provided this, just to remind everybody, we are provided this online sessions in first and third week of the month. And we are welcome all of you to be whom interested to present challenging cases or topic. Just contact us and we will arrange this. So now, Dr. maybe Yasser, can you just like have short introduction about Dr. Saif and his topic?
Thank you, Dr. Seja, and welcome everyone. This is always my home, and Dr. Isa is aware about that, and Dr. Daoud. So I started my journey in nephrology back in Sultan Qaboos University Hospital, Muscat, Oman in 2009 as a renal registrar, and my first line was performed under the supervision of Dr. Seja. So it's my pleasure and honor to introduce a close friend and a colleague, Dr. Saif Al-Chalabi, who is a graduate from Iraq 2010. He got his MD from Buckingham in 2017, and he's a PhD candidate. To be honest, he already submitted his thesis. He's just awaiting a date for the Viva, and he has done his PhD under the supervision of Professor Kalra, and he's also a final year specialty trainee in renal and general medicine, and he should finish hopefully within less than 6 months, inshallah ta'ala. One is of his PhD and his interest is mainly about renal cardiac and the metabolic disorder, and he will take us through this for the next 30 minutes or so. And we should be able to have the questions at the end, unless Dr. Seja or Dr. Isa wants to have the questions like during the slides themselves. Whatever you prefer, we are happy with. We are very flexible. Saif, the floor is yours.
Okay. Assalamu alaikum, everyone. Thank you for the invitation. I'm really honored to present today. And thanks, of course, for Yasser to give me this opportunity. So I'm just today presenting this title, Beyond CKD, the overlap of renal cardiac and metabolic disorders. We all nephrologists here, I think, but we all see patients with diabetes and also cardiovascular problems. And it's probably, I think this is very relevant. And hopefully by this talk, I will convince you these are not three things. This is actually one thing we should look at in our patients and treat as a whole in one basket rather than three different things. So the, right, let me see. You see the second slide, yeah, Yasser? Everything's okay? Yeah, it's rolling, yeah. So the outline of the talk is basically, I will touch quickly on the relationship between CKD from one side and the other, cardiovascular mortality and diabetes, of course, type 2 mostly, and also obesity. This is big thing, so I'm just going to touch on a few numbers basically. And then I will talk about the concept of the cardiovascular kidney metabolic syndrome, which was conceptualized in 2023 by the American Heart Association. Then I'll talk about landmark trials for the last 4 years and how this is shaping our specialty and also our collaboration with other specialties. And then at the end, I will talk to you about results from our clinic in Salford, showing you that actually looking at patients with these 3 conditions altogether, it actually works. And hopefully it improves survival and renal outcomes as well for these patients. So this is one of the, I think most of the common slides you'd see in an renal talk. This is from 1999. It is basically showing the cardiovascular mortality for patients on dialysis compared to general population. So the top 4 lines, the white ones, are the people on dialysis, and the 4 black lines with black dots are the people general population basically. And you can see the mortality risk of people with, let's say, 25, 34 years old on dialysis. Cardiovascular mortality is equal to 85 years plus general population. So it's a huge risk of cardiovascular mortality in people on dialysis. And we know this is not just on people on dialysis. We know this is across the spectrum of CKD. And this is these are basically the hazard ratio of cardiovascular mortality in every group of stage of CKD and also albuminuria. And you can see the G4A3, for example. People with G4A3, they have anything between 5 to 18 times increased risk of cardiovascular mortality compared to general population. It's a huge risk of cardiovascular mortality. As we all know, of course, it's a top 1 killer in our patients with CKD, unfortunately. And the mechanisms how kidney failure or CKD can cause heart condition, there are multiple factors, I think, and it's summarized in this Nature review. It's basically you have our stuff on the top right. So we have anemia, of course. We know anemia is very important. People with CKD that have lower erythropoietin secretion. And also they have lower span of red blood cells as well. They bleed easier, they have lines, they can bleed from their fistulas, so they always have anemia. We know this accumulation, the anemia, of course, we know from the iron study and other studies actually, that lower iron is actually associated with lower outcomes in people with heart failure. So they always benefit from IV iron, which we usually assess and treat actively in people on dialysis and, of course, CKD. Other things are accumulation of uric toxins, and there are hundreds, probably thousands of toxins that we're not measuring. We measure urea, creatinine, and other things, but there are hundreds probably of toxins that we don't measure routinely for our patients. These all can affect the heart. Of course, the sympathetic overactivity with renin, angiotensin, aldosterone system activation that affects the heart. Inflammation, general inflammation from CKD, and increased oxidative stress. There are also shared risk factors between CKD and cardiovascular diseases, like hypertension is a very good example of that. You have, of course, smoking as well, which can play part in both problems. Hemostatic abnormalities, bone mineral metabolism. We know now FGF23, the reduced secretion of FGF23 due to CKD is associated with more cardiovascular mortality. Sodium and volume overload, of course, causes more heart failure because of stretching of the heart and causes heart failure, of course. So the outcomes that can cause because of CKD, you can have stroke, heart failure, venous thromboembolism, of course, AF, sudden cardiac death, which is a big problem in people with dialysis, and you have aneurysms and peripheral artery disease as well. So moving to type 2 diabetes, this is a map which I like to show, just showing the regional world data about, this is the data for people with type 2 diabetes in the world, how much they have CKD on top of that as well. And you can see our area, unfortunately, is all painted with red, the whole Middle East and also the whole Arab world, actually, mainly, especially Iraq and Oman. Oman, I think, is slightly less, 24 to 49 cases per 100,000 patient, but still really high risk of CKD in people with type 2 diabetes. much more than the rest of the world, unfortunately. For the obesity, this is a paper we published just to look at the relationship between CKD and obesity. And obesity can cause direct, there's a direct route to cause CKD, which causes ORG, the obesity-related glomerulopathy. But also, obesity can cause indirect effect on the CKD via these routes. So you can, of course, have sodium retention because of Niki's adiposity that can cause hypertension and then can cause CKD. It has also sympathetic nervous system activation, of course, hypertension. The insulin resistance, of course, can cause diabetes and then can cause CKD. RAS activation as well, and also adipocytokine secretion that can cause inflammation, oxidative stress, and that will all cause albuminuria and CKD. So obesity as well, which is quite linked with diabetes, it can also cause CKD. So hopefully I'm now, of course, the relationship between these conditions, but I'll just give you also a few numbers as well, how this is getting worse over the last 20 years and how the problem is really significant. All these obesity, diabetes, CKD, and heart failure, they're all really linked together. So for example, there are more than 90% of patients with diabetes, type 2 diabetes, are living with overweight or obesity. We know this, of course, and this is getting worse, of course. For type 2 diabetes patients, there's a big study showed only 6.4% of those people they have actually in isolation with no other elements of cardiometabolic diseases. So there's no heart problems, there's no CKD, it's only in isolation. So there's 93.6% they actually have other conditions as well with it. And in 2019, there was 1 billion people around the world have CKD and diabetes. And this figure has increased by 28% over the last 10 years. So it's a huge increase in the risk of these conditions recently. And I think that's because of probably diet, the way we live, the food we eat, all the sedentary lifestyle and everything that we do at the moment compared to 50, 60 years ago. It's all different, and it's all causing these problems to go hand in hand and causing severe increase in mortality and morbidity for our patients. Of course, the last one is just heart failure, and it's also linked with diabetes and CKD, and both of them is 16% as well. So now I'm going to talk about the conceptualization of the cardiovascular kidney metabolic syndrome, so CKM syndrome. So you might be aware of that. So in 2023, only 2 years ago, the American Heart Association, due to this huge links between these conditions, they say let's name it a syndrome, and then hopefully we can target with more policies and guidelines, and we just look at these patients as a whole rather than looking at an organ in each patient, so that the patient doesn't have diabetes, go to diabetologist, and they have CKD, they go to the nephrologist. They actually, let's look at them as one person having 3 conditions, and we can treat together in one place. So this concept was defined by the AHA, and they consulted a group of cardiologists, nephrologists, endocrinologists, as well as primary care physicians. And I think they play a central role in this problem, because, as you know, early identification of people with CKD diabetes actually can lead to better outcomes. So hence the GPs or the primary care physicians, they are actually have integral role in here. So the definition of it's basically, it's a systemic disorder characterized by pathophysiological interactions among metabolic risk factors, CKD, and cardiovascular system that leads to multi-organ dysfunction and higher rate of adverse cardiovascular outcomes. Of course, they're focusing on cardiovascular because they are cardiologists, but of course, in total, this syndrome also causes worse kidney outcomes in terms of rapid decline in eGFR, more dialysis, more end stage, of course, CKD other than a continuing CKD at the same level. And CKM syndrome includes those at risk for cardiovascular diseases and as well as people with existing cardiovascular diseases. And I think this is the concept that is different from metabolic syndrome. Sometimes when I give this talk, the people say, oh, this is the same as metabolic syndrome. Why we name it differently now? Metabolic syndrome, I think, was in 1990s, and it has few definitions in the past, and I think only one of them, I think the WHO classification or the criteria for metabolic syndrome includes albuminuria. So the CKD is not well represented the metabolic syndrome, but it actually should be. And the other problem with metabolic syndrome is it only discusses the risk factors, so people at risk of problems rather than people with actually having problems at the moment. So this CKM syndrome, I think, is more inclusive of people, of a wide range of people with risk and also established. And they have 5 stages of CKM syndrome as suggested. So you have stage 0, where people are active, they don't have any increased adiposity, and they don't have any cardiovascular or CKD or diabetes. That's stage 0. Stage 1, so they're all linking it to adiposity. So increase or excess dysfunctional adipose tissue. This is stage 1, where people have a bit of obesity, could be central obesity. As we know now, BMI is not enough to suggest this patient has obesity. It's actually there is central obesity as well, which is, I think, more common in East Asian and in the Middle East as well, compared to other countries. And central obesity is also highly linked with these cardiorenal metabolic conditions as well. So central obesity as well, not just the high BMI, can be also in stage 1, which leads to impaired glucose tolerance and of course insulin sensitivity as well. Stage 2, here where you have metabolic risk factors and CKD, you have hypertension, you have hypertriglyceridemia, type 2 diabetes, and also CKD. Stage 3, where you have subclinical cardiovascular diseases like subclinical heart failure or subclinical coronary artery diseases. For stage 4, you have actually clinical evidence of CKM syndrome. You have established heart failure, fibrillation, stroke, peripheral arterial disease, or congestive heart disease. Coronary heart disease. I think in stage 4 they have A and B, where A people on not on dialysis and B people on dialysis, because we know the risk is a lot higher when people they are on dialysis. These are the stages suggested by the AHA in 2023. And the pathophysiology of CKM syndrome can be summarized in this slide actually. So you can look at the top one, where you have excess dysfunctional adipose cells. These secrete cytokines and adipokines, and these can cause inflammation, oxidative stress, insulin resistance, and vascular dysfunction. This in turn can cause effect on the kidneys, causing glomerular sclerosis, CKD of course, affects the heart, causing atherosclerosis, dysfunction of the cardiac muscles, and myocardial remodeling. It also causes diabetes and hypertension. And you can see there is a special crosstalk between the kidneys and the heart through the albuminuria and the bone mineral disease, of course. And so it's all linked together, and we should actually be looking at it is one thing that we're looking at than 3 different things. So now we'll talk about some risk prediction for mortality for CKM syndrome. We know there are loads of calculators to predict risk or mortality. I think our cardiology colleagues, they have, I think, really advanced calculators, the Q risk, and I think there are lots of other things. The problem with these calculators, we have also KFRE, for example. The problem with the calculators is it's organ-specific one. So it doesn't really include real patients. So when you have a patient with heart failure, you're ignoring CKD, for example, by looking at cardiovascular calculator. When you're doing KFRE, you ignore the fact that they had an MI 2 months ago, for example, and it doesn't have even mortality, the KFRE, for example. So hopefully they made a prevent. This can be accessed online as well. It's called Prevent Online Calculator, again by the American Heart Association, which actually has all the parameters you need for these patients to predict their 10 and 30 years risk of cardiovascular diseases, in people between 30 and 79 years old, but they shouldn't have known CVD. So any people with previous MI, for example, or previous strokes, they can't be included in this one. This is for people who has no CVD before. And it's actually good data. I think they have more than 3 million participants from 25 data sets, and it's well validated by other publication, I think, where they looked at other 21 additional data sets. So you can use this to predict cardiovascular diseases and mortality for patients with CKM syndrome. Now we'll talk about the landmark trials, which I think is closely linked to CKM syndrome. So this is the Credence trial in 2021. I think this has got a big interest. And I remember, I think I presented in the International Society of Nephrology. And I remember people were cheering during the presentation of that because people got very excited about that was canagliflozin and the renal outcomes in type 2 diabetes and nephropathy. So there were, as you know, this was a huge win for people with diabetic kidney diseases. And we know that for 30, 40 years, we only have the RAS inhibition for these patients. And we have lots of patients with diabetes and CKD, and we can only offer them RAS inhibition. But then after this trial, we can actually offer them SGLT2 inhibitors, and has a really significant reduction in risk of primary outcomes and end-stage kidney disease, as you previously know. That's from 2021, the canagliflozin, the Credence trial. And then what they did, I think post hoc analysis of the Credence trial showed people actually with no diabetes can actually also may benefit from dapagliflozin or SGLT2 inhibitors in general. So they done the DAPA-CKD trial, and that was in 2020 after a year. And DAPA-CKD is actually, it has 67% diabetes, but actually also has people with no diabetes. And it showed really good outcomes still for people with no diabetes on SGLT2 inhibitors taking dapagliflozins. And there's a good reduction in risk compared to placebo. And then after that trial, we're now using SGLT2 inhibitors as a renal medicine rather than a diabetes medicine. And we can give it to people with high ACR, EGFR above 20, even without diabetes. And then we got the IMPA-CKD, the empagliflozin with another SGLT2 inhibitors, which they extended the albuminuria criteria and actually still showing really good results. So even people with low albuminuria and not really significantly high albuminuria, they can also benefit from SGLT2 inhibitors. And I think I have a slide here showing you these three trials and how much they are using. The population of the trials is where they sit on this KDIGO risk chart. So the Credence you can see is the green one and sitting on the top there. So it's using slightly less risk people from DAPA-CKD, for example, which goes down, I think, to 25, I think, EGFR. And then the IMPA-CKD went down to 20 EGFR. But you can see the ACR covering the whole thing from normal albuminuria to very high albuminuria. And DAPA-CKD, of course, it has people without diabetes. So I think SGLT2 inhibitors, it shows you how actually a diabetes medicine has a good cardiovascular outcomes and also good CKD outcomes. Hence, the link between these three things is very appropriate. And then we have the FLOW trial, which is a more recent one in last year. The FLOW trial was talking about the semaglutide. We all know the obesity jabs that also given to people with type 2 diabetes and CKD. And we saw also hazard ratio reduction of 0.76. So there's 5.8 events per 100 patient years for people on semaglutide. So it's great results for our patients, and there's an extra medicine that we can use for people with diabetes and CKD. And we already know from other trials that semaglutide has also cardiovascular benefits as well. The last one, I think I will just want to talk about that landmark trials is the recent one. I think that was from last month, published in New England Journal of Medicine and I think presented in the European Society of Nephrology. So I think that's a very important trial, called the confidence trial, where they use epinephrine, which is the a mineralocorticosteroid inhibitor with empagliflozin together to see the outcomes of ACR reduction and eGFR as well. So they both use them together starting the same time, and you can see there's a huge reduction when using both compared to each one of them in the figures. And if you so there's I think 30% reduction in ACR over only 180 days. So there's a huge improvement in ACR over only short time. And also the other thing that I want to show you is once they stop in 180, they deliberately stopped giving them the medicines. And you can see from day 180 to day 210, so over a month, all the proteinuria effect of these medicines just gone, washed off. And that means that actually these people, these medications actually, it's a chronic medication like you give diabetes medication, when you give heart hypertension medications. These are chronic medications, and we would like to keep our patients as long as we can on them because the effect will be better if they are on this medication for longer. And it's a good example when people get admitted to hospital for, let's say, acute kidney injury, and they have their dapagliflozin stopped or finerenone stopped, for example, and unfortunately sometimes never even restarted because of whatever reason or get forgotten about restarting it. And that's a huge risk for our patients. We have to really actively getting our patients back on these medications so they can actually get all the benefits of them. And I think the second important feature of this trial is show you can actually give both in the same time. We're not as good as cardiologists yet in giving patients good medications, the pillars of medication, basically same time. We usually start RAS inhibitor and then up titrate slowly over weeks or months, depend on your service, your provision of service, and then you may do some dapagliflozin. So it takes really months and months to get them on RAS inhibitor and dapagliflozin, maybe and finerenone and semaglutide. It takes a really long time, and we're actually losing nephrons, losing kidney function, losing also heart function when we actually delay giving these patients. And once they stop it, we don't restart it, they actually also lose. So we need to restart as soon as possible and actually continue for as long as we can. And the trial didn't show significant hypotension, AKI, or hyperkalemia. And I think compared to compare between empagliflozin and finerenone and the combination of both. For the finerenone, I think I have a slide. Yes, because it's a fairly new one we're starting, and there's always risk of hyperkalemia because it's MRA and people are a bit worried about starting it when people have a bit of hyperkalemia. I think different countries have different policies, but this is from the UK Kidney Association 2024. The indication currently in the UK for finerenone is the patients have to be on maximum tolerated dose of RAS inhibitors and SGLT2 inhibitors. eGFR has to be 25 or more, ACR has to be more than 30, and potassium less than 5. And they say you need to reduce the dose from 20 to 10 if the eGFR is 25 to 50 rather than more than 60. So these are the current guidelines we're using. That's why probably patients are not on this medication as many as people on SGLT2 inhibitors or RAS inhibitor, of course. So I hope so far I convinced you actually these medications and the way the pathophysiology of these conditions, they actually make sense to look at our patients as one whole patient rather than looking at organ-specific problems. And I think suggested treatment for patients with CKM syndrome, I believe is first is as normal as we all know, and for all conditions is diet and lifestyle advice. Of course, exercise, healthy diet, These are all important first-line management. We need to frequently monitor our patients with eGFR, albuminuria, lipid, blood pressure, anemia, of course. These are all important parameters we need to monitor and correct as well. And we need to ensure patients on the maximum tolerated dose of RAS inhibitors. And sometimes we challenge patients to give them more and more dose to give the best benefit of these medications. And after that, we can use other medications as we know now. We know the SGLT2 inhibitors. We can use GLP-1 RAs if it's available. I think there's a huge supply issue now with GLP-1 RAs, and also Fenirenal, of course, if potassium is allowed and with monitoring of potassium. Any questions so far? Because next I will talk about the research results we have from the clinic in Salford.
Yes, there is one question from Dr. Fadi in the chat box. What is the current evidence supporting international weight loss as a therapeutic strategy in patients with cardiorenal metabolic syndrome, and how does it impact cardiovascular and renal outcome?
Yeah, so weight loss, of course, I don't think there is any trials because I think it's difficult to do a trial like asking people to we lose weight and not to lose weight and then look at it. But I don't think we need a clinical trial to suggest losing weight can actually benefit our patients. We know, I think losing even 3 kilos, I think from research I saw recently, can actually reduce the cardiovascular risk of mortality like 5% over the lifespan of the patient. We know obesity is actually a problem with diabetes, of course, with CKD as well. So actually, I think it's intuitive to think that losing weight will actually hugely impact our patients, and they should reduce the risk of general mortality risk. Hisham Al-Sayed raised the hand. Yes?
Yes, thank you very much, Dr.
Okay,
Saif. I'm
thank you.
Hisham Saidi, CNT President-elect, Professor of...
Oh, we lost you.
Prof. Hisham, I
Oh,
think the internet is not stable.
unfortunately.
Dr. Sajah, he mentioned that there was a problem with the internet in Egypt
Yeah,
yesterday.
so
So if there is no other question, probably we can continue the lecture and then we wait for him to come back. Probably he
Yeah.
can ask the question, but without the video, if that's okay.
yeah, sure.
Okay, so next I will talk about, so this all theoretical. I'm talking about all the syndrome and all these patients and the landmarks, and then I will just show you now. This is like not as unpublished results, I would say. We have a special clinic in Salford called the MRC clinic, Metabolic Renal Cardiac clinic in Salford, where we see people. It's actually run by nephrologists, this clinic. But we have the input from diabetes and also people from the heart failure as well. So we see people with these conditions and try to give them the medicines.
I'm sorry for the interruption of internet today and yesterday in Egypt. If you can get back to my questions, because it's important.
Yeah, sure.
What's your about the cutoff of starting not sequential, as proved by the confidence? You may try to start as cardiologist the 3 pillars, RAS inhibitors, SGLT2, and the non-steroidal MRA. But the GFR itself, we need a cutoff. The confidence drop around 6 milli per minute when combined both together at the start.
Yeah.
So I think we have to put a cutoff to start both or to start sequentially for the adding eGFR drop. What do you think about that? How you can implement that with a cutoff point?
Yeah, I think the eGFR drop is a very important thing, and we saw that these nice figures were even with dapagliflozin and the credence trial as well. It showed this dip in eGFR when you start these medications, and we think this is basically just restarting the system inside the glomeruli, as you know, Professor Said, and it's just basically because it's lower the pressure inside the glomeruli. So actually, the filtration gets damaged, but then the long-term outcome is actually better.
Yes, I understand the mechanism. My question here, I have 2 to 3 milli per minute GFR drop once I started the SGLT2, and additionally 2 to 3 minutes when I started Renal. If I start both together as a sum, as proved before, calculated publications, and in the confidence, you have higher GFR drop when you start. My question is still not clear for the guidelines when you can combine both of them, at what level of GFR it's safe to start both together. Because 6 to 7 milli sharp drop of GFR may have a worsening of some retention of uremic solids.
Absolutely.
So do you know from your vision, because there is no data up till now, if we can start maybe later on when GFR above 30, which is behind the 25 of Renal and away from SGLT2 20. So if the GFR is 30, you can combine. If it's below 30, you have to do sequential. Just the brainstorming about the guideline should be.
That is correct, actually. That's indeed, it's a risk of dropping the eGFR more if you give the medicine the same time. I understand. I think there is no real evidence, and everyone is avoiding giving all this sort of like very accurate measurement and the eGFR. You can start 2 or 3 medications same time because there's no data at the moment. And
yes,
of course, it's hard to tell. But then I think it's general term, as you know, it just if the eGFR has been stable for a long time and probably they are in a good shape and they don't have any problems, I would start them both. I don't know, maybe above 30, I would be happy to start both. Below 30 will be, I think, a bit hard because you may touch that point of, oh, we're going to be 20 soon. So you will be at higher risk. But we actually want to see them early, isn't it, Prof? So we want to see them when they are 60 or 50 GFR, so we can actually give them better outcomes in the future.
It will be a happy life if I see my patients with GFR 50. Mostly referral will be below 30 and putting the nephrologist in the corner.
Yeah, that's why I think.
So I think just the brainstorming that we have to put a cutoff point of GFR 30, which is 5 milli beyond Renal and 10 milli beyond the SGLT2. So when you combine and you can drop 4 to 6 milli per minute, you are still in the safe. I think just I'm just giving my feelings in clinics.
I think that's correct. And I think for now it's difficult, but I think above 30 is a safe level, as you know. Hopefully more data will come and show us more. The good thing that we know it will correct itself. So the 6 that we're losing, we know this is going to be regained again. So yeah, exactly. So that give us a bit more hope that this will actually not give harm to our patients. But I think hopefully more data will come because this is very rapidly evolving place actually here, and then going to be lots of trials happening hopefully the next 2 years. So we're going to know more about these.
Okay, thank you. I will keep my second question to the end.
Okay.
Just one comment on what Professor Sayed said. So it's a very good question, but there is no answer to it. And I would say the practice in UK, there are 2 different groups. One where they will start like, everything at the same time, regardless of the GFR. I call them very brave, like, very, and they do everything regardless of the GFR. Like even they started when GFR is 24 and they say, I don't care, even if the GFR is dropping by 10. I am from the other group, which is the conservative group, they call it here, where like when the GFR is around, let's say between 25 to 35, there is no cutoff, I'm just saying it. I do them one by one because my worry, my concern is most of the patient, if not all, are getting the results now on their application and all of that. And when they see the drop in the GFR from 32 to 25, they panic, they press the panic button, they call everyone. And also, as a comment to what the Saif said is, like even those who initiate everything, you want to see them quick, but what happens in the real life, and I'm sure it's an issue everywhere as well, is I start XYZ medicine and I say I want to see the patient again in a week time. Again, that would be a happy life if we can see them in a week time, but sometimes due to logistics, the annual leave, the pressure on the clinic, you ask for 1 week and it ends up being 2 or 3 or 4 weeks, and then in between the patient get the results done, it goes on their app and the panic button is there and everything. So I follow the approach that Professor Said mentioned on the group, but I was said to be a member of the conservative, not the party, I mean, conservative group of nephrologists.
Thank you, Yasser. Unless there is emergency like HFrEF, you have to start whatever behind the GFR. So if the patient is not in HFrEF, you can wait and sequentially adding. I think so. That's a wise decision. Thank you very much.
I just need to add something as well. So I think different patients maybe can deal with them differently. So there are patients who actually listen to you and they can attend their appointments, for example. They can actually know what's happening with them. So you can actually try with a bit more brave approach with them. But some people, they don't engage with the clinic, they don't come. So I think it's very hard to give them these medicines and they don't come for 3-4 months and then something happens to them. I think it's all patient-centered approach, of course, and not just the eGFR number. Okay, no, that's very good point. Thank you, Professor Said.
Thank you.
Right, so I will just talk about the clinic. So the impact of integrated CKM care we have in Salford. I won't talk about the background because we've done that already. So just going to evaluate the outcomes of the Salford CKM, so which is called the MRC clinic, the Metabolic Renal Cardiac Clinic, and we compare it to standard care. So and talk about methodology. So the clinic was established in 2021 by a team of nephrologists, and they have special interest in cardio and diabetes. And of course, part of this is Professor Kaller as well. So we have input from heart failure MDT, diabetologists we have also, and we also have diabetes nurse specialists. They can all help us in MDTs for difficult patients, and we have regular meetings with them. And the way we refer, Yasser would know, so the way we refer patients to the MRC clinic rather than the general nephrology clinic is if they have a more complex need usually. So a good example, if you have like an advanced heart failure patient trying to give them ACE inhibitors and they having repeated hyperkalemia and AKI, that's a very good patient for the MRC clinic, so we can actually manage there. So the patients enrolled between March 2021 and end of February 2024 were included in the study, and we have follow-up until April this year. So the outcomes, I compare the outcomes of the clinic with the standard care. We have the Salford kidney study, which is more than 4,000 patients in the study with CKDs, basically. We've been recruiting them from 2001 and it's ongoing at the moment. So I used group of them between these years 2019, 2023 to compare with the MRC clinic patients just to see if there's a difference in outcomes. And because of the differences between the two groups, this normal CKD cohort in the SKS, but in the MRC you will have, I will show you now the characteristics. We have more obese patients, we have more heart failure, more diabetes. And so the difference between them is difficult. So when you do propensity score matching between the two cohorts, you actually won't get a good matching between them. So I use something called overlap weighting analysis, where you basically give propensity scoring for everyone, but you give more weights to people around the midline. So you can actually have exactly matched two groups, and then we can see the outcomes between these groups. I will show you the results now. So for the MRC clinic, just looking at it, we have more than 500 patients came in the clinic for this around 4 years. We had 72 years old median age and 63% were male. And you can see we have huge percentage of people with diabetes and also heart failure, more than 66% diabetes and 62% heart failure. And that's also reflecting on the BMI. The median was 31. The eGFR 36, the median, so that's really low eGFR, and the UACR is 58. So this cohort of patients, the problem with the clinical trials, they don't use this cohort of patients. They always use patients with lower risk. So we actually have really high risk cohort of patients, and it's not a clinical trial, of course, but we're trying to do our best to look at these high risk patients, which is underrepresented in the clinical trials. This is the uptake of medications in the clinic. So the baseline means when people came to the clinic, they were on these medications, and the second column is when we added during the follow-up, and the total at the end. So the RAS inhibitors were around 56% of patients were on RAS inhibition before attending the clinic, and then we added 60 people on top of that, 11.5% more. SGLT2 inhibitors, you can see 27.9%, added 21.4%, and the total was around 50% of them, they are on SGLT2 inhibitors. We use GLP-1 of course, potassium binders, good use as well, just to allow the maximum dose of RAS inhibition. So we gave lots of potassium binders to patients who they are needed to keep them on the right medications. Beta blockers, you can see there's high percentage of beta blockers because you have high percentage of heart failure, and also MRIs as well we use in the clinic. So that's the improving. I'm just showing you how we improve the uptake of these medications, and some of these medications were already actually in either referred by cardiologists or referred by our nephrology colleagues or from GP referrals. And this is a delta eGFR. That's the change of eGFR before attending the clinic and after attending the clinic. Although the p-value was 0.563, so that's not significant, but it's actually the median was minus 0.87 before, so nearly losing 1 mil of eGFR per year before attending the clinic. After the clinic was basically just running in a straight line, minus 0.04. But because of the huge, I think the range of the data, the p-value wasn't significant. But it shows you there's something happening in the clinic that we are reducing the delta eGFR. So this is the MRC patients in the MRC clinic versus the people in the sulfate kidney study. So this is the total. This is the people in the MRC. This is the SKS. And you can see the p-values mostly are less than 0.001. So it's a huge difference between the two cohorts there. So the MRC, they are a lot older than the SKS, 72 to 61. The BMI is 31 versus 30. The heart failure and diabetes a lot more. The stroke, the previous stroke, COPD, the use of RAS inhibition, the urinary ACR as well, 58 versus 34. The eGFR was 36 in MRC compared to 45 in SKS. So a lot more higher risk patients in the MRC clinic. So this is the raw analysis. So that's the pre-matching analysis showing the follow-up. So the follow-up for the MRC was median 16 months compared to 34 months in the SKS. The mortality risk was a lot higher in the MRC clinic, was 19.7% versus 8.5%. This is pre-matched analysis. So looking at just the risk of them, and of course they die more in the MRC because they have more risk. End-stage kidney disease outcome was fairly similar. Delta eGFR was different. So there was a minus 1.84 in the SKS, reduction in eGFR, versus minus 0.04. Then we did the matching with the overlap weighting and propensity matching, basically. So the red dots are the pre-matching, the unadjusted, or we can say the green dots in the middle. You can see these are the matched cohort, and they're actually all on the zeros. So we corrected for all the things that I showed you, for the age, gender, all the cardiovascular, diabetes, all the bloods, eGFR, and urinary ACR is all corrected for, and we all got very good, zero matching, so perfect matching basically between the two groups. And when we match them because of the different risk, we get these results. So for the top one, for the all, so the all-cause mortality for 2 years was actually 0.31 in the MRC clinic compared to SKS. So you have 69% reduction in mortality risk in the MRC clinic, with a very good p-value, of course. And then we thought this could be because of the SGLT2 inhibitors, because there's a bit of difference in the timing of the SKS and the MRC, but that's actually still showing 0.43 reduction. So that's a 57% reduction in mortality in people in attending the MRC clinic compared to the SKS. And because of the follow-up differences, you can see the dot for follow-up here is a very different between the two groups. So we recruited people with more than 2 years follow-up, and we still have 46% reduction in mortality in people in the MRC clinic compared to the sulfate kidney study. Still similar end-stage kidney disease outcomes. So after matching, it's not a clinical trial, but when we matched it with the best we can, we actually saw when we get all these patients in one place, we can actually improve their outcomes. And there's a significant improvement in outcomes, especially in mortality risk, which are around 46% better mortality reduction. There are limitations, of course, in this research. So, as I said, the baseline characteristics were very different. So we used the overlap weighting analysis. The group recruitment was a bit different. So for the MRC was 2019, 2024 versus, sorry, that's the SKS. The MRC was slightly later, 2021, 2024. So we ruled out people on SGLT2 inhibitors, but still showing significant results. And the follow-up was different, 16 versus 34 months. So we omitted people with more than 2 years, and that's still showing, I think, 46% reduction in mortality. Conclusion. So that's for the whole thing. So I hope I so far convinced you that cardiovascular, kidney, and metabolic diseases, they often coexist and share common pathophysiological pathways. And we know they are now, over the last 3-4 years, they're all targeted with same medications. So the RAS inhibitors that we used for years now targets the heart, it also targets the albuminuria and the CKD. Now we have also SGLT2 inhibitors, GLP-1 RAs, and also MRAs. So they all have very good evidence. They work on all these conditions. They reduce weight, they reduce blood pressure, improve CKD outcomes, improve cardiovascular outcomes, and they actually also diabetes medication. So high-risk patients should receive comprehensive coordinated management to improve long-term health outcomes, and attending the MRC clinic or CKM service in general, it was associated with significant reductions in mortality in people with CKM syndrome. And that's it. Thank you.
Thank you so much, Saif.
Thank you.
Any question? So I might have a question myself, if that's okay, just to know the practice in different countries. So we're trying to promote GLP-1 analog, but we're having a significant national shortage of the medicine. So many patients were on the NHS, they are having to be on the waiting list before getting the medicine because of the demand in the private sector. So I'm just wondering whether you're facing the same problem in Oman or in Egypt or in other places.
Thank you, Dr. Yasser. I think we have similar problem for like even as a GL2 inhibitor, we are maybe just recently adopted in the polyclinic only, not only like in at the level of the primary healthcare sector, if I'm not wrong. Prof. Isa, we can correct me. Also, the GLP-1, I think just recently, maybe 1 month, we started in the endocrine clinic. We don't have yet like starting the integrated clinic. Maybe this is a good idea to start really to collaborate with our primary healthcare provider, at least at the level of the polyclinic, like start this integrated clinic to adopt the preventive strategy, especially in Oman. We have like quite, according to the local registry data done by Prof. Isa and his team, I think it is like quite 10 years back, but still diabetes is the leading cause of end-stage renal disease in Oman. And what is make it different from other population, they are younger age group to have end-stage renal disease. Actually, the average like age people in Oman reaching the end-stage renal disease less than 50 years. So really, we should adopt preventive strategy with this the new concept of CKM. It was very interesting, Dr. Saif. Thank you, and it is very nice to highlight the problem and also to share your strategy, the new strategy to solve such problems.
Thank you. Thank you. Appreciate it.
So we had the same problem with SGLT2 inhibitor between 2019 and 2022 when prescribing in the primary care was a bit of an issue, but it's not an issue anymore for the SGLT2. Finerenone, there was an issue in 2023, 2024, but now it's also again sorted and there is what we call a shared care protocol, but it's mainly the GLP-1 because of the national shortage, because of the demand in the private sector, like people with the BMI of probably 25, 26 are asking for it because they're willing to be 22 and 21. But it's good to know the different in the practice between different countries. I can see Professor Sayed is raising hand, then we'll take the comments, if that's okay, Dr. Saja.
Yes, thank you
Yes,
very much. Actually, I'm in the steering committee for implementing guidelines in the CRM or CKM, whatever you are from Europe or from the USA, to implement that universal, although not more than 30% worldwide, even USA, are escaping from implementing the guidelines, and most of the patients are stopping RAS inhibitor and also additional drugs. So it's basically a worldwide problem for implementing of the GDMT and to be assured that all are the same and the sequence of that. I think I have only one question. You perfectly mentioned of the confidence study that once you stopped the SGLT2 and finerenone, everything is then back, which makes me worry, and I asked Agrawal himself during the era for the confidence trial. You are promoting finerenone as an anti-fibrotic and anti-inflammatory drug that prevent progression of CKD. So why you have to stop that? You return the albuminuric effect, although it's not a hemodynamic effect. So why? I don't know. I didn't get the answer even from the author. The curve, you perfectly mentioned that. I understand that you can get that from SGLT2, but finerenone is not a hemodynamic effect. It's an anti-inflammatory and the anti-fibrotic effect.
Yeah.
Do you have any explanation?
Yeah, so to be honest, so that PhD at 2021, my PhD actually, and when DAPA was coming and the canagliflozin coming, I was just thinking that to me, there must be something hidden in the pathophysiology we can't see with these medications. Because how come you have a medicine that can reduce weight, improve CKD outcome, improve heart failure, it's a diabetes medication. So there must be something we can't see inside the body that's actually causing that. I don't think we understand wholly the pathophysiology, and it's probably something we don't know that is causing that with the finerenone. But I don't think we understand the full pathophysiological pathways of these medications, how they all work together. I think that's the reason, basically. But I don't have
I think it's behind the anti-fibrotic effect because it's not a long-term effect, it's a temporary effect.
Yeah.
My second question, yes, it's a growing incidence of diabetic kidney disease phenotypes of non-albuminuric diabetic kidney disease, which is very common, and rapid decliners of GFR common in diabetic phenotype kidney disorders.
Yeah.
Due to diabetes, we know that the pathology, we know that the immunostaining and differences between both and the macrovascular and versus microvascular complication. My question, is finerenone here will be of value, non-albuminuric diabetic kidney disease progression?
Yeah.
Do you prescribe finerenone for a diabetic patient whose albumin creatinine ratio is below 100 or below 50, for example?
Yeah, so at the moment, the finerenone is really restricted in the kind of the prescription by the UKKA, the UK Kidney Association. So I'll show you, I think, the slide. That has to be the eGFR. I think certain is 20, more than 25, and the ACR more than 60, and they have to be on full RAS and full SGLT2 inhibitors to give the finerenone as well at the moment. That may change in the future. So we're slightly limited, and you probably, I didn't even put the finerenone. You can see the numbers are very small on this clinic because we are very restricted in giving finerenone in these patients at the moment.
Yes.
Okay. But yeah, I think the DKD, the diabetic kidney disease, I think is a difficult topic because how often we do biopsies for them? I think mostly we assume these are DKDs because they have diabetes for 10 years. But would they actually all get biopsies? They might have something else we don't see. So I think it's difficult with DKD. There was a good Nature review saying there were
Yes,
yeah,
in the literature, in non-albuminuric diabetic kidney disease has less mesangiolisis, has less C1q depositions, less mesangial expansion, less Klein-Stein or nodular sclerosis. They have a specific phenotypes. But I think my answer will be solved within 2 years when Ferinone will be added in non-diabetic CKD.
exactly, yeah.
So, like SGLT2, and I think this is maybe by next year or after that, in the Ferinone CKD trial, it's not finished yet. It will solve the problem and answer my question, I think so.
Yeah, I think lots of
Thanks
trials.
again. I really enjoyed. I am sorry for interruption because my internet is not stable.
No, it's all right, don't worry. Thank you so much for your input. They're really
Thank
good
you.
points that you mentioned. Thank you.
Dr. Yasser, maybe there is another one question about the use of SGLT inhibitor in dialysis patient.
Yeah, so I think that's a big thing. We don't have
End-stage disease and dialysis
Yeah, I
patient.
know. So I think there's no guidelines regarding this, but I think if you're a patient above 20 GFR and you put them on dapagliflozin and they progress to end-stage kidney disease, I think if there is another indication for them to stay on it, for example, they have heart failure, I think keep them on that, providing they are okay with this. There's no side effects. Just keep them on that medication, I think. But there is no. This is like a. I'm not going to say expert opinion, but I think that's an opinion for people share and they do actually in practice. I think that's a sensible thing to do, just to continue, even if they're on dialysis, if they have another indication for it, like heart failure.
So these 3 groups were excluded from trials to answer this. One is the dialysis patient, and one is the PKD patient, and one is the transplant patient. So in our center, we're currently enrolled in a trial where we are using it for transplant patient. So we tell the patient it's an off-license use on a trial basis, but dialysis and PKD is yet to be answered. Do you use it in Oman or Egypt for dialysis or PKD or transplant, Dr. Isa or Dr. Sayed?
From my side, yes, in 2 scenarios. One scenario is who are already on SGLT2. I wouldn't initiate. It's forbidden. Below 20, I will be very worried about that. But who are continuing on starting incremental dialysis, I would give it impact 10 milligram or DABA to continue in incremental way during dialysis, because in literature that it can preserve the GFR and ongoing renal damage. The second part is, I believe that in patients, exactly as you said, that in HFrEF, on dialysis, they cannot compensate of even 1 liter of volume overload with heart ejection fraction, 30 or 35%, and they do well. It's off-label, yes, but they have an independent pathway of the heart failure. So I continue on SGLT2. The ketosis and the other complication is rarely seen.
Correct.
UTI, I never see a UTI with SGLT2 inhibitors, significant mycosis or other amputations or thrombosis or such complications. So I believe that a patient going on dialysis, we can continue on 2 scenarios. One scenario, incremental dialysis to preserve GFR, and second part, if the patient has heart failure.
And do you use it?
Professor Isa, we can hear from his opinion.
Do you use it in Egypt for PKD and transplant patient?
We have a trial here in Egypt in transplant, yes. And we believe but also that it have a value beyond renal transplant itself. For the PK, it's going polycystic kidney, but I'm still aware about that. Even tolvaptan, I'm still aware from tolvaptan, so I cannot go for SGLT2 in polycystic kidney.
Yes.
Professor Isa.
Yeah, thank you very much, Saif. And Saif and Yasser. As Saja alluded to, really in Oman, we follow quite very strict criteria and the utilization of medicine. So really, even the DABA, let alone Fineron, is not really is that available. And sometimes even to prescribe it, you have to fill a special form. There are always restriction about how to use, and only by highly specialized individual. And that's a policy throughout. You know how it is, Yasser. And it is because to reduce the actual cost and contain it and make they concentrate on other general thing in the primary health care. And hence we do not use it that often. What we noted in particular in the DABA, because Oman is very hot country, and it is depending its mechanism on throwing a lot of sugar in the urine, that's many of our patients develop AKI because of dehydration, not taking much fluid. So we noted that's quite usual case where the drop is significant, even higher than 30%. And some of those, even I noted some family member of mine, I could not explain it. And Dr. Deeb and myself were always to and fro discussing about these various patients, because the cardiologist, Dr. Deeb Muhammad, probably aware of, he prescribed it commonly. They come to me, that their kidney function dropped significantly, used to be above 65, 70, now it is in the 40. I said, you have to keep up. Either you accept the treatment, and here is a patient-centered approach in many of these aspects. You accept that to have a GFR in this way, but you are protected overall, you just follow up. Or that's been at least will reduce the dose. If you are not happy with it, you consider other modalities of therapy. But we do find that issue is quite significant. And possibly one of the things which we even discussed more than 20, 30 years, which is available in certain medication, whether to combat such cardiovascular, kidney, metabolic disorder really, is by having sort of single, triple therapy, like if they can combine really ACE or ARB with Fineron and DABA, and whether that will be the future, I don't know. That's the floor is for you guys to discuss, and possibly Saif can shed a light on such a problem.
It's very interesting to see that AKI, although in the literature, maybe in Europe, it's another scenario in the environmental factors, because usually SGLT2 inhibitor from the meta-analysis that is lower incidence of AKI noticed while the patients having SGLT2 as an observational study retrospectively. So, but as you exactly and perfectly say, Professor Isa, that another country, another environment, and another world may change the face of the medicine.
Yes, that's what we noted. I think it's all due to the actual environmental issues. And like many of these medication, even the immunosuppression, our Dr. Nabil Mohsin published long time ago, what we require even as TAC level is by far lower than what is utilized in Europe and North America. And we found this sort of discrepancies goes on quite commonly across many sort of medication and disorder. And we opted now, we have one PhD student to look at measuring the actual or adjusting the dose of medication immunosuppression, mainly tacrolimus, by using genetics rather than really applying the serum level of tacrolimus in our population. And hopefully in the coming 2 years, we'll have some publication about this. It gets all to do with genetics and environmental factors.
Thank you, Professor Isa and Professor Sayed. Saif, one more question to you from the chat. Oral GLP-1 analog versus subcut injection?
Yeah, I think it's a class effect rather than a medication effect, just like the SGLT2 inhibitors we saw. I think it's a class effect, so I think oral. I don't think we can say unless we have a clinical trial, because as this is what's happening with the SGLT2 inhibitors, we have the dapagliflozin now for the heart, for example, because we have more heart failure trials with dapagliflozin. So, and then they use more by the cardiologist other than the, sorry, the empagliflozin actually used more by the heart failure, people, than dapagliflozin because the link with the clinical trials. But I think it's a class effect. So hopefully we can see more clinical trials are going to be the same effect.
Agree. Perfect. So any other question? Okay, so I will leave it to Dr. Sajjad to end the session.
Thank you all. Very interesting topic and very fruitful discussion. And thank you, Dr. Saif and Dr. Yasser, to have you with us. And I hope we will see you in the future as well. It is very interesting. Thank you, Prof. Hisham Said, for your contribution in the discussion.
Thank you all.
I will come to the end. Yes. By the end, I
Thank you very
want to
much.
announce, if you allowed me, to invite you to join our third annual OSNT International Nephrology Conference. This will be in September from 4 to 6 in Salalah city. So all are invited, and don't miss the opportunity to connect and learn and lead the future of the nephrology. Welcome all. Thank you.
Thank you
Thank you very much.
Thank you,
Thank you so much
guys.
for the
Thank you.
invitation, and thank you so
Thank you.
much for the contribution.
Thank you, Saif. Thank you, Yasser.
Thank you, everyone.
Yasser, we are using in the transplant, the SGL2 inhibitor.